have two patients that walk into your office, both with mood swings and insomnia. One has bipolar 1 disorder and the other has bipolar 2. Can you tell me which is which? Hi everyone, I'm Dr. Georgette Kui, a psychiatric provider, and today we are going to break down how to differentiate bipolar 1 disorder from bipolar 2 disorder using the DSM-5 criteria. We are going to discuss when and how bipolar disorder can be diagnosed, what conditions must be ruled out. We are going to review validated screening tools that support accurate diagnosis. By the end of this video, you will understand the key diagnostic differences between bipolar 1 and bipolar 2, how mania and hypomania present in each disorder. We are going to look at when and how bipolar disorder can be diagnosed, what medical and psychiatric conditions to rule out, screening tools used in clinical practice. We are going to look at treatment goals, FDA-approved medications, including newer options like Vraylar, Calypta, Uzedy, and Fanapt, also known as iloperidone, and finally some clinical pearls for healthcare providers. But before we dive into it, let me tell you about a tool that is transforming clinical practice. If you're a healthcare provider, you need to know about Companion Medical Scribe AI. It is an artificial intelligence powered software that was built by healthcare providers for healthcare providers. It can help generate detailed clinical notes in seconds. It can help suggest diagnosis, differential diagnosis, provide ICD-10 and billing codes, recommend medications and dosages, and even answer clinical questions with evidence-based responses. It is also HIPAA compliant, works across all medical specialties, and is truly a game changer for clinical documentation and decision support. So if you're looking for something that can save you time, improve accuracy, and streamline your workflow, definitely check it out. Now, let's get into today's topic, bipolar disorder. So bipolar disorder are mood disorders characterized by episodes of depression and either mania or hypomania. The DSM-5 provides clear criteria that helps clinicians distinguish bipolar 1 from bipolar 2, and understanding these differences is important for accurate diagnosis and effective treatment. Bipolar disorder typically emerges in late adolescence or early adulthood, with the average age of onset between 18 and 25 years old. However, symptoms can appear earlier, even in childhood or adolescence. In children and adolescents, clinicians must be cautious. Mood fluctuations, irritability, impulsivity can overlap with ADHD, disruptive mood dysregulation disorder, or normal developmental changes. Diagnosis in this population requires longitudinal assessment, collateral information, and careful exclusion of other causes. So let's look at the diagnostic criteria. Let's start with bipolar 1 disorder. To diagnose bipolar 1, a person must have experienced at least one manic episode. A manic episode lasts at least 1 week or any duration if hospitalization is required. The symptoms cause marked impairment in functioning. They might require hospitalization or can even include psychotic features. Depressive episodes often occur but are not required for the diagnosis. Now, with bipolar 2 disorder, it requires at least one hypomanic episode and one major depressive episode, but there must be no history of full manic episodes. The hypomanic episode lasts for at least 4 consecutive days, is noticeable to others, but does not cause severe impairment or require hospitalization. The depressive episodes are typically longer and more impairing than the hypomanic phases. Let's look at how mania and hypomania present. Mania, which defines bipolar 1 disorder, is a period of abnormally elevated, expansive, or irritable mood with increased energy or goal-directed activity. People in a manic episode often sleep very little or not at all, and they still feel energized. They might talk rapidly and jump from topic to topic. They might also have racing thoughts. They might have inflated self-esteem or grandiosity, that exaggerated self-esteem, feeling like they have special powers or talents. They might engage in risky behaviors like excessive spending, impulsive sexual activity, or reckless driving. They might sometimes develop psychotic symptoms such as delusions or hallucinations. Mania is severe, disruptive, and often requires hospitalization. Hypomania, which defines bipolar 2 disorder, on the other hand, shares similar symptoms but is less intense and shorter in duration, lasting at least 4 days. The person appears more energetic, talkative, and productive, but without major impairment or psychosis. Hypomania can feel pleasant or even advantageous, which sometimes delay diagnosis. In contrast, the depressive episodes in bipolar 2 are often more frequent and debilitating. So what are we going to rule out before diagnosing bipolar disorder? Before confirming a diagnosis of bipolar disorder, clinicians must rule out several medical, psychiatric, and substance-related causes that can mimic manic or depressive episodes. For medical conditions, you need to rule out thyroid disorders, especially hypothyroidism, neurological conditions, infections, autoimmune diseases like neurosyphilis, vitamin deficiency like B12 deficiency, endocrine disorders like Cushing's disease, substance-induced causes like stimulant use, steroid medications too, antidepressants or dopaminergic agents that can trigger mania, even alcohol or drug withdrawals too. Psychiatric conditions to rule out. You want to rule out major depressive disorder without hypomania or mania, ADHD, overlapping symptoms of hyperactivity and impulsivity, borderline personality disorder. You want to rule out schizoaffective disorders, cyclothymic disorders. These are very important to rule out. A comprehensive medical history, physical exam, laboratory testing, and collateral information are essential to ensure diagnostic accuracy. Some screening tools that we can use for bipolar disorder, the common ones, we have the mood disorder questionnaire, the hypomania checklist. Then we also have the bipolar spectrum diagnostic scale, young mania rating scale, even the rapid mood screener. The key distinguishing factors between both is that bipolar 1, there is full mania, severe, impairing, possibly psychotic. Bipolar 2, there is hypomania, which is milder, shorter, without psychosis, plus major depression. Psychosis and hospitalization is common with bipolar 1. Depression dominates the cause of bipolar 2 disorder. So let's look at management and treatment goals. The main goals of treatment are to stabilize the patient's mood, prevent symptom relapse, improve functioning, and minimize the side effects of medications. Treatment usually combines medications, psychotherapy, and lifestyle interventions such as maintaining regular sleep, exercise, and avoiding substance use. FDA-approved medications that can be used, we have lithium, which is the gold standard for mania and maintenance. We have Depakote, which is effective for acute mania and mixed episode. Lamotrigine, which is best for bipolar depression and also maintenance. Atypical antipsychotics like quetiapine can be used for mania, depression, maintenance. Lorazepam for bipolar depression. Cariprazine, which is Vraylar for manic, mixed, and depressive episodes in bipolar 1. Olanzapine/fluoxetine, which is Simbax for bipolar depression. Risperidone and aripiprazole, ziprasidone for manic or mixed episodes. So let's look at some newer and emerging medications like Calypta, which can be used for bipolar depression in both bipolar 1 and bipolar 2. Uzedy, which is risperidone extended release. It is a long-acting injectable which can improve adherence. Fanapt for acute manic or mixed episodes in bipolar 1. Evidence-based therapies too can be used like CBT, psychoeducation, family-focused therapy. They are important to prevent relapse, symptom relapse, and also medication adherence. So let's talk about some clinical pearls for healthcare providers, especially psychiatric providers. You want to screen early for bipolar disorder. It often begins in adolescence or early childhood. Rule out medical, substance-induced, and psychiatric disorders that might mimic bipolar disorder. Use validated screening tools to support diagnostic accuracy. Avoid using antidepressant monotherapy in patients that have bipolar disorder as it can trigger mania or rapid cycling. Vraylar and Calypta show efficacy across mood poles with favorable side effect profiles. Uzedy improves adherence in patients with poor medication adherence. Fanapt is another one that expands options for acute manic or mixed episodes. You also want to emphasize maintenance therapy. Discontinuation is a leading cause of relapse. So when these two patients walk into your office, both with mood swings and insomnia, please remember that bipolar 1 is defined by mania, which is intense, impairing, and sometimes psychotic. On the other hand, bipolar 2 is defined by hypomania and major depression, which is subtler but often more chronic and disabling. Diagnose confidently by considering the age of onset. Use validated screening tools and rule out medical and substance-related causes. Again, I'm Dr. Georgette Quay. Thank you for watching. If you found this video helpful, follow more for more evidence-based mental health education. And please don't forget to check out Companion Medical Scribe AI, which is the future of clinical decision making and also documentation support. Thank you so much.